Hi, my name is John Vu. I'm a medical oncologist practicing in Jacksonville, Florida at Baptist MD Anderson. In this video, I'll be reviewing 4 abstracts presented at ASCO 2021 in locally advanced non-small cell lung cancer, a study looking at limited stage lung cancer and radiation, and a study evaluating treatments in metastatic mesothelioma. The first trial I'll be reviewing is the IMpower 010 study. This was a clinical trial evaluating patients with stage 1B to 3A non-small cell lung cancer with a performance status of ECOG 0 to 1 who were treated with lobectomy or pneumonectomy followed by adjuvant cisplatin-based chemotherapy. Patients were randomized in a 1-to-1 fashion to receive either atezolizumab every 3 weeks for 16 cycles or best supportive care. The primary endpoint was to evaluate disease-free survival in 3 populations. The first is the stage 2 to 3A population who were PD-L1 positive. The second is all randomized stage 2 to 3A population, irregardless of PD-L1 status. And the third is the intention to treat population stage 1B to 3A. Secondary endpoint was to look at overall survival in the intention to treat population and the disease-free survival specifically in the PD-L1 above 50% expression in the stage 2 to 3A population, and the 3 and 5 year DFS in all 3 populations. The results of the study showed that patients who had stage 2 to 3A non-small cell lung cancer, irregardless of PD-L1 status, who were treated with atezolizumab adjuvantly following chemotherapy, had a median disease-free survival of 42.3 months compared to best supportive care of 35.3 months. This equated to a stratified hazard ratio of 0.79 with a p-value of 0.02. When that same population of stage 2 to 3A was looked at who were PD-L1 positive, the median DFS was not reached at 32.8 months when the study was extracted, compared to best supportive care of 35.3 months. The estimated hazard ratio was 0.66 and the p-value of 0.004. In conclusion, this study was the first phase 3 study demonstrating disease-free survival improvement with adjuvant immunotherapy in stage 2 to 3A non-small cell lung cancer. In the patients who had stage 2 to 3A and PD-L1 positive, the hazard ratio was 0.66. And those who had a PD-L1 greater than 50% had a hazard ratio of 0.43. All randomized patients, stage 2 to 3A, had a hazard ratio of 0.79. And the disease-free survival in the intention to treat population, including stage 1B, did not cross the significance boundary at the interim analysis, and the OS data was immature for this study. The safety profile of atezolizumab was consistent with prior experiences using the medication, and atezolizumab, based on this study, may be considered a practice-changing adjuvant treatment option for PD-L1 positive patients, stage 2 to 3A non-small cell lung cancer. The next study is the VIOLET trial. This is a multi-center study in the UK in patients with known or suspected lung cancers, clinical stage T1 to T3, N0 to N1. They were randomized in a 1-to-1 fashion to receive VATS surgery or open lobectomy. This study is an update, 1-year update from that trial. What the authors found was that VATS lobectomy was associated with less pain, significantly lower total complications, shorter length of stay achieved without any compromise to procedural oncologic outcomes, such as lymph node dissection, upstaging of mediastinal lymph nodes, or complete resection, or serious adverse events. In addition, there was superior recovery continued after discharge with improved physical function and in the vast majority of secondary measures of quality of life up to 1 year. Less complications and readmissions continued to be observed after discharge without any difference in recurrence, disease-free survival, and overall survival at 1 year. The VATS technique is both more effective and less costly compared to thoracotomy based on this results of this trial. The next study is the CALGB 3610 study, evaluating limited stage small cell lung cancer, comparing two arms of radiation, 45 gray BID over 3 weeks versus 70 gray daily for 7 weeks. Patients were given this radiation regimen along with concurrent chemotherapy with a platinum etoposide-based backbone. The primary endpoint was to evaluate whether the 70-gray daily radiation was superior compared to the 45-gray BID radiation. In conclusion, they found that there was no significant improvement in overall survival comparing the 70-gray daily versus the 45-gray twice a day. The median overall survival of the 45-gray twice a day regimen was 28.5 months, and the median overall survival for 70-gray daily was 30.5 months with an insignificant p ratio of 0.591. The final trial that I'm reviewing is in metastatic mesothelioma. We know that Vinorelbine exhibits useful clinical activity, but has not been formally evaluated in a randomized clinical trial, despite its widespread off-label use. This study included patients with malignant pleural mesothelioma with an ECOG performance of 0 to 1, and who received prior platinum-based chemotherapy with disease progression. They were randomized to receive Vinorelbine 60 milligrams per meter squared orally on days 1, 8, and 15 on every 3-week cycle versus best supportive care. The primary outcome measure was to establish the anti-tumor activity of Vinorelbine as measured by progression-free survival. The study showed that the median progression-free survival of Vinorelbine versus best supportive care was 4.2 versus 2.8 months, with a hazard ratio of 0.6 and a p-value of 0.002. Thank you for your attention. This concludes my video summary of the ASCO 2021 abstracts, select abstracts in locally advanced non-small cell lung cancer, limited stage small cell lung cancer, and metastatic mesothelioma.